I'm Daniela Luquetti. I'm going to talk a little bit about clinical and phenotypic data. I'm at the University of Washington at the Seattle Children's Research Institute as well. I'm an assistant professor there. And my main interest is in etiology, so causes of birth defects, more specifically craniofacial, and I'm working on microtia and craniofacial microsomia. So I think a lot about phenotype as a medical geneticist. Here on this first slide, I'm trying to show for microtia, so the underdevelopment of the external ear, kind of differences of how it can be presented. And then at the clinic, what we want to know when we see a patient like this is we and the parents is, why did this happen and what are the genetic causes of microtia and the non-genetic ones. So in summary, what is it that happened? And it really starts with the phenotype. What is it that we're seeing and how is it that we're going to study it? So I like to think about it, phenotype, as external and internal differences. And so the external differences will be the more obvious ones usually. And so easier to ascertain, like microtia. It's easier to see that the ear didn't develop fully. But there are also the internal differences that, of course, are less obvious. And then ascertainment will depend more on image. So I'm talking about ultrasound, CT, MRIs, like heart defects and kidney defects. And sometimes we can also add for phenotype, neurodevelopment, social development, race, ethnicity. It depends a little bit what we're studying and how we're seeing it. And the thing about phenotype ascertainment is that it can be, as I said, obvious, and we can receive the data as a code. And the other two presentations by Deanne and Melissa already talked a lot about coding of conditions. So here I have the ICD-10 code and the human phenotype ontology codes for microtia. And we can sometimes receive the photo as well. But for all the other systems, for example, the heart or the kidneys or the liver, the question is, was it normal or was it the abnormality was not described? So it wasn't just sent or coded, or was it not tested for? So not all kids with abnormalities will have a full scan. They shouldn't have it. But then the question remains when we're grouping these conditions and we're saying, for example, that this child only has microtia, for example, are we really grouping the same type of conditions if we don't know what are their internal anomalies, for example? So that would be one of the challenges with phenotype ascertainment. And the other thing is that we need coding because we would like to see the photos, all the photos, because that's where we have the most of the information. But the reality is that we need to have some kind of code so that we have some kind of spreadsheet where we can actually do the data analysis. And the codings, they need to be at least specific enough. They should account for severity and for laterality as well. And that's sometimes where the challenge is, and I think Melissa talked, and Deanne also talked a little bit about those challenges about the coding. And the other thing with coding is that we tend to lose, we tend to lose a little bit of information. And so here we have what we're seeing with our eyes in a newborn with microtia. And then here's the doctor when he's, examining, and there's this very detailed phenotype, what he's seeing about the ear, the anomaly of the ear canal is not present. How is it that the ear did not develop well and the right side being normal? And when we start transcribing that, even to a medical chart, we start losing information. So when it's transcribed, it might be microtia type 3 on the left ear, and the ear canal is atretic. And sometimes as we keep going, then we have just been microtia type 3. And when we go further on for coding, then it can be just a code, just microtia and just microtia second degree if we're using the human phenotype ontology. So it's clear how we're losing information in this process. And for some things, there's no way to correct that or to have all the photos hanging there to analyze them. And so I think the two things to remember here is that we are losing information. So the code that we're seeing, it's not all the story, but also trying to think about getting the coding systems to be as specific as possible. And in the bottom here, I have this cartoon adapted from Chilean, where he's showing exactly that. So how you're losing information, and the dotted line is what I imagine being in the database compared to the patient will be on the letter A over there. So when I work with statisticians, they always ask me why I'm focusing so much on phenotype, why all this detail, why can we just say, microtia or cleft lip or whatever it is. And so the premise really is that specific conditions will be caused by very different mechanisms, genes or exposures. And so the better we define the phenotype, the better our chances of finding causes of a given condition. And it could be that, all types of microtia are caused by the same mechanisms, the same genes, and the same exposures. But it could be that it's not, and that's already been seen for cleft lip and cleft palate, for example, where first we thought it was just one condition, and through the years we were able to see that they're actually caused by different genes. So that's our focus, is to have the best phenotype we can, to then, after we are able to make the connections with the genetic and non-genetic causes, to be able to see if they are the same or not. So those were kind of the phenotypic challenges that I see, and the way I think about it, and the way we're trying to think about the data. And then the other part is the prenatal exposures. And I really like to think about this phrase that when a baby is born, it is already 1 year old. So a lot happened. There's the whole pregnancy, 9 months, and the pre-pregnancy period. And there could be a lot of exposures during all that period. And our memory is not that good. So when the baby is born, it is already hard to ascertain what is it that happened on a specific day that could have been the cause of that condition or not. And so when we're thinking about the prenatal exposures history, we're thinking about exposure to non-genetic risk factors like tobacco and alcohol, medications, and so how to standardize those questions. I think PhenoX is trying to do that, and I think it's a very good tool. Although for prenatal exposures, it's not, the work is still in progress, so we still don't have all the questions there. But I think it's a way to work through that. Well, in every study, that'll be my utopia. Every study we would use the same questions, but we don't have that yet, and so the work really is on how to get all the data coming from different studies, even from the same investigators sometimes, and harmonize the data from different questionnaires, from different ways that the question was made, different modes, if it was an interview or if it was a survey, or other ways of gathering data, medical records review, and then age of data collection, as I said before. So it's a very different information if you're collecting a prenatal exposure at birth than if you're collecting it from an adult or even a 5-year-old. So thinking about all that and how we would account for that. So basically, to find the causes of birth defects, we're thinking about integration of data. So integrating the subphenotypes, the prenatal exposures, as I said, the family history, which I didn't talk a lot, but we want to know if there are other people affected in the family, and what is it that their phenotype is, if it's the same, if it's similar, if it's a subphenotype. And then finally, the genetic differences. So combining all this data to be able to find what is it that is causing birth defects. So what the future looks like, so having a minimal data set, standardized phenotype and exposures coding, coming from the standardization of the questions as well. And I think one thing that Deanne was already talking about, but it's very interesting and important, is to know how is it that the data was acquired in each study, and to account for that as not known or not asked or missed, those are very different kinds of missing data. So if the echocardiogram wasn't done, then we actually don't know if there is a heart condition or not, whereas it's very different from having an echocardiogram and being normal, of course. We're also thinking about developing methods to code phenotype from photos, so kind of an automatization of at least external differences directly from photos, trying to get that to work, and all that to setting the ground for future studies where we'll use standardized questions and methods developed through the group. That's all I had to say. Thank you.